So I see, yes, I'm in now, so thank you. The next, please. Sorry for that. So I just to present me, I granted this clinic 8 years ago, and in this time we make 36,000 surgeries, and I make 550 shoulder surgery per year, and more than 11,000 in the last 18 years. The next, please. The next, yeah. So we know the anatomy factors. I think it's not a question for tonight. I will speak about the rotator cuff because this is the most important thing for tonight. The next, please. I try to be quick. The Coleman cadaver examination, we know he found in 100 cadaver 61 rotator cuff without any surgical or treatment disorders. And I think a lot of people has rotator cuff tears without any symptomatic, but I think we should speak about the symptomatic patients. The next one, please. So the patient's way is examination and ultrasound, the MRI, and we should decide if they need a surgery or not. We begin always with an arthroscopy, and then we go to a total joint implantation. The next, please. I think the ultrasound and the MRI is the most important for us. So every patient gets an X-ray and the ultrasound and the MRI, and we can decide if they need a surgery or not. The next, please. We have some protocols for all the patients and for the instability or the rotator cuff tears. The next, please. Our indication guide is we focus on the outlet impingement with acromion form and osteophyte, and all the patients with a rotator cuff rupture, they are symptomatic or partial rupture. They will get a recommendation for the surgery. The next one. So for me, the curved acromion to type 2 is one of the interesting anatomical situation for the surgery, because the patients, I think they will need earlier or later a surgery in their life. This in the left, this anatomically situation, what we see in the surgery too. The next. We have a great range of indication for our surgeries. I think we make all our lesions arthroscopically. We don't open any shoulder in the last 20 years. The next, please. So 80% of the surgeries are performed because of the rotator cuff rupture. And this is our particular patient group for tonight. 90% is treated is a satisfactory result after this surgery. And however, I think 2 to 8% of the patients have continued to recurrent pain or weakness following the arthroscopic rotator cuff, and they require another surgery too. The next, please. Some statistical data from Germany. You see on your left, the open operation was 59,000 in 2005. Nowadays is 48,000. Even it's a huge number. I think this surgery is. I think we should make it arthroscopically. I don't think At 2020, we should open a shoulder because of the rotator cuff tear. The next, please. I use the Kovacs classification for the rotator cuff tears. The next, because it's easy to understand for the patient to make a difference between the small, medium, and a large rotator cuff tear. The next, and of course, the next, yeah. This is the picture what I show the patients to understand the different type of tears. The next. And of course, the massive rupture with all the retraction, atrophy, and probably fatty degenerations. The next. However, the factors influencing the results are the joint motion before the surgery, the size of the tear, the condition of the muscle of ruptured tendon, and the concomitant shoulder diseases, muscle strength, and of course the quality of the reconstructions. 80-90% of the cases are success and excellently resolved. The next, please. So we need some technical requirement and expectation. We need, as we heard, a primary fixation and stable and correct anatomy reconstruction. There are on the market a lot of fixation techniques, just 2 or 3 from this. I am very comfortable with the giant needle technique. I think this is the surgery which made the most strength fixation. The next. Because almost all the other procedures involve screw implantation with no specific complication such as displacement, dislocation, or loosening of the implant. I see a lot of patients which I need for the second operation to me make in another hospitals, and the loosenings percent is very high. So for me is the only technical method, the giant needle, which provides the complete refixation and without any implantation. The next. The giant needle technique was described by Dr. Pfleger, 2002. He has been using the technique since 1919 as an alternative to the open surgery, as we heard. So the underlying idea from him was this technique that with these special needles, with suture passed through the tendon and bone, or tendon to bone, unrestricted by any portal, and simply passed through the skin, tendon, and bone in one step, tying a knot in another step. But the most important thing is, for me, I think, is that we don't need any hardware implants for the surgery. The next. So this is the situation where you see the rupture and the anatomically preparation for the supraspinatus, and with yellow you see the most possible tears what we have. The next. So this is the you can see how we pull the giant needle to the skin and the supraspinatus and the bone. The next. And yes, I put my name there because of this almost 12,000 surgery with a giant needle after Dr. Pfleger. But this is he just presented the surgery, so I don't have to make it twice. But I think it's a technique which is very comfortable, and yeah, we have very good results. The next. So you see how we pull the thread through to the tendon and to the bone and make the knot. The next. We it's very important for me to make the bone refreshing. If you can see, if you can show us the film, the video. Okay, then. Yes, please. So this is what I want to see, the bleeding. Yes, the next. Massive rupture. You see the biceps, and the one step to the another with the treat. So we can make more 3, 4, or 5 nodes to get the rotator cuff together with the bone. The next, and you see on your right how it make the nodes one after the other. The next, and if I see that it's a small part which is not coming together, I can make a 4th or a 5th stitches, and we have the complete reconstruction of the tendon. The next. Another advantage of this technique is that we can make intra-articular incomplete ruptures too. The next, you can see how I put the giant needle to the capsule intra-articularly and make the node outside from the capsule, but you see the fully reconstruction. The next, tendon to tendon. It's a 20-second result. It's very quick and good technique. The next, another tendon to tendon situation with a complete refixation. The next. So the giant versus screw, I know it's always a problem, and it's a question. The next, please. What I see sometimes the problematic is that we can't pull the retraction to the bone, and you can see on your right down, it's not a fully contact to the bone. The next one. So I can bring together the two parts of the rotator of the tendons and try to pull the tendon to the bone. The next. Anyway, it's you see the screw. The next one, please. And I think almost is necessary to complement with a giant needle fixation, and the two techniques together bring a better result than just one in such a cases like this. The next. So the advantage of the giant needle technique is a strong fixation. I want a strong fixation, anatomically and strength of cuff fixation. We don't need any implants. We can make tendon to bone, tendon to tendon, and intra-articular sutures, and it's compatible with any other technique together. The next. So the first 10 years results after 5,600 patients. So we have 81% of rotator cuff reconstruction. The rest was labrum and tendinitis calcarea, or capsular rafting together with a labrum refixation. The next, please. The average years was 90.
Dr. Kovacs, it's time, please. So yeah, can you hurry up?
Yes. The next. Then. Okay, so you can see the results. I mean, we have 3% poor results, but the rest is good or excellent. Okay. Thank you very much, and sorry for this complication.